Hello and welcome to today's webinar presented by Dr. Jeremy Gilbert, Insulin Therapy, How to Choose with So Many Options. This is a great webinar. Very excited for you all to see it. Great topic. Lots of information that Dr. Gilbert is going to run through today. Wanted to let you know this video was recorded, so you're watching this on demand at a time that works for you. But there is still an opportunity for you to participate in the discussion. If you have questions or thoughts or anything else that you would like, you can join us at community.diabetes.ca. If you head to our community forum, there will be a discussion group about today's webinar. You do need to be a member to join in to the Q&A discussion. If you are not a member, you can become one at diabetes.ca/membership or at 1-800-BANTING. You could give us a call or send us an email and we'll set you up with a professional membership. Then you can head to community.diabetes.ca and join in, chat with other folks who work in diabetes and healthcare, be in the know. Lots of great reasons to do that, including getting to discuss today's presentation with Dr. Gilbert himself. Without further ado, I'm going to pass it on to Dr. Gilbert.
Welcome everyone to this Diabetes Canada webinar entitled Insulin Therapy, How to Choose with So Many Options. My name is Dr. Jeremy Gilbert, and I'm an associate professor at the University of Toronto, and I work as faculty at Sunnybrook Health Science Centre. I'm currently the Royal College Chair for Endocrinology and Metabolism through the Royal College of Physicians and Surgeons in Canada, as well as a national editor for the Canadian Journal of Diabetes, and have been very pleased to be affiliated with Diabetes Canada in many roles, including chairing the Dissemination and Implementation Committee for the Diabetes Canada Guidelines, being a member of the Steering Committee of the Diabetes Canada Guidelines, as well as an author in chapters of the Diabetes Canada Guidelines in 2013 and 2018. So I was asked today to talk about insulin therapy, and this webinar will be recorded and archived for people to watch at their leisure. If there are any questions or comments, I'd be happy for people to email me. You can reach me at jeremy.gilbert@sunnybrook.ca, and happy to have an ongoing dialogue of discussion, as this topic certainly lends itself to great discussion and topics. In a short webinar, there's no way to cover all of the material associated with insulin therapy, so much to discuss. So I've selected a few topics and I hope you find it interesting. So I'll just put out my disclosures over there. I work with a variety of different companies and organizations, largely related to diabetes education. I don't do research, but wanted to acknowledge all of the different disclosures I have right there. And for this webinar, hope to discuss the advantages and disadvantages of different basal insulin therapies, consider the role that biosimilar insulins have in managing diabetes, and then review some of the practical considerations around prescribing insulin. So a lofty set of objectives, but I think these are some of the important topics, certainly to talk about insulin therapy. Again, recognizing that we're not going to be able to discuss insulin pump therapy. We're not going to be talking about glucose monitoring associated with insulin therapy, hypoglycemia, treatment and management. There's so much to think about with insulin, but for a focused webinar that we have today, we're going to try and address these three objectives. So let me begin actually with the Diabetes Canada guidelines and acknowledge that with assessing glycemic control, cardiovascular and renal status, dietary patterns and weight change, understanding where the A1C target should be, certainly involving the diabetes team approach with our educators, and acknowledging the value of healthy behaviors. For type 2 diabetes, we generally begin with metformin and consider additional agents if the A1C is greater than 1.5% above target. But for the purposes of this webinar, let me remind you that insulin is still recommended right at the get-go for those who have symptomatic hyperglycemia or metabolic decompensation, such as diabetic ketoacidosis or HHS. So it's just a reminder that insulin therapy is really used throughout the spectrum of management of type 2 diabetes, and of course, for all of those who are on type 1 diabetes. Now, our 2020 guidelines do have some specific recommendations around insulin therapy. And again, as we think about insulin therapy and how we're approaching this, I think it's always good to see what our current Canadian guidelines have to say on this. So they do say that in people not achieving glycemic targets on non-existing anti-hyperglycemic medications, that the addition of basal insulin should be considered over other options, such as pre-mixed or bolus-only regimens. And then certainly if lowering risk of hypoglycemia and preventing weight gain is a priority, which I would say is certainly the case in almost all of our patients. So in adults with type 2 diabetes who are on basal insulin therapy, if minimizing risk of hypoglycemia is a priority, and again, when is minimizing risk of hypoglycemia not a priority, almost in everybody, then long-acting insulin analogs like glargine U100, glargine U300, detamir, and degludec are recommended generally over NPH insulin to reduce nocturnal, meaning overnight, and symptomatic hypoglycemia, and that's a very strong grade A, level 1A recommendation. Insulin degludec or insulin glargine U300, known as Tresiba or Toujeo, may be considered over glargine U100 to reduce overall and nocturnal hypoglycemia, with slightly less evidence for those who have more than one or more risk factors for hypoglycemia, and as well for those individuals without risk factors for hypoglycemia at a lower grade of evidence, and as well for those who have severe hypoglycemia. So the point is that long-acting insulin analogs generally recommended over NPH, and then second generation agents like degludec or glargine U300 may be recommended over first generation basal analogs, specifically to address overall and nocturnal hypoglycemia. And I'm not going to get too much into the details of MDI or kind of stepwise beyond basal insulin therapy in great detail today, but again, kind of referring back to our Diabetes Canada guidelines, if a decision is to initiate insulin, and this is why I included it in this particular webinar, and the fasting glucose or the A1C is not a target, and basal insulin is initiated and then of course titrated, as it's not only about initiation, but titration is key, then we titrate to a fasting glucose to the set target. If beyond that, meaning that the fasting glucose is at target, yet their A1C is still elevated, then before going to bolus insulin, to think about GLP-1 receptor agonists, SG2s or GPP4 inhibitors before going to bolus insulin, and then adding bolus insulin in a stepwise fashion with the largest meal per day. So that is, again, from our guidelines with the purpose to trying to get A1C to target within 3 to 6 months. So it's an exciting webinar to talk about because the evolution of insulin products is phenomenal, and Canada should be very proud since 1921 with the isolation of insulin, and then the development over the years. So NPH, Lantus, we don't really have anymore, and then in the late 70s, recombinant human insulin, moving beyond animal insulin, the development of rapid-acting insulin analogs, basal insulin analogs, and more recently, biosimilar insulins. And so for the next little while, that was kind of where I'd like to focus on to try and get a better understanding of the roles of these agents today. So if we think about the three types of insulins, there's bolus insulin, there's premixed insulin, and basal insulin. And given that our guidelines saying that, when you're starting insulin, the best way to begin is generally with basal insulin, I thought my focus would be on that for this webinar. And then, of course, happy to address any further questions or comments that may come through. So basal insulins certainly are getting better and better, and each advance has resulted in a better profile. And understanding the benefits of these newer generation basal insulin analogs comes down to understanding how they work. So let me show you how they work in terms of insulin action on the y-axis and length of action on the x-axis. And you can see NPH tends to have this peak with the duration of action around 16 to 18 hours. And it's that peak that leads to higher hypoglycemia and perhaps why it's less preferred as a basal insulin. And then we have the development of glargine U100, such as Lantus or Basaglar, insulin detamir like Levemir. And while flatter than NPH, they may not last always the full 24 hours, and also tends to have still a little bit of a peak action, which could lead to hypoglycemia. So the next generation basal insulins, like insulin glargine U300, called Toujeo, or insulin degludec U100 or U200, known as Tresiba, tends to last longer. Glargine U300 around 36 hours, degludec up to about 42 hours, and that allows a flatter curve. So you see less variability. You also, it allows you to use these insulins as a once an injection per day because it's lasting more than that full 24-hour period of time. Just to show you how this works, so in terms of the action, glargine U100 looks like this. Glargine U300 is concentrated at about a third the value. That's why it's 100 versus 300. And therefore leads to a smaller depot under the surface of the skin, perhaps maybe even leading to less lipohypertrophy at the insulin injection sites, but certainly more comfortable to inject a smaller volume, especially for people who are on large volumes of insulin. Insulin degludec is a larger molecule that releases one monomer at a time slowly, which leads to, again, for its very long duration of action. And because of the long duration of action, both of these products really are truly a once per day injection. You can also see on the left how it's flat. Same thing with Toujeo and Tresiba, and that flat profile leads to better variability, not as much ups and downs, less risk of hypoglycemia, and a more flexible type of insulin to be administered. So there's been numerous trials on second generation basal insulin. The addition trials looked at Toujeo compared to Lantus. The begin trials looked at Tresiba or degludec compared to Lantus. We've had comparison trials between the two products of glargine U300 and degludec with the BRIGHT and CONCLUDE trials, and more recently the ENRANGE trial. And the long story short is that there are certain implications of all of this evidence together, which I've tried to summarize in this slide. But these second generation basal insulin analogs have the advantage of that extended action profile, stable glycemic control, very little difference in actual A1C reduction, but for that same A1C reduction, less hypoglycemia with more flexibility, once a day dosing, and smaller injection volumes, which are especially appreciated for people who are on larger amounts of basal insulin. The comparison between them, in my mind, suggests more similarity than differences. And while there are some subtle differences in the BRIGHT study and CONCLUDE study and other real world studies, largely these two agents are very effective at lowering A1C when titrated properly, can give great efficacy as well as great safety. And this is encouraging. The most recent trial to this is the ENRANGE trial, which was presented only a few weeks ago and then subsequently at the American Diabetes Association meeting last week. And I have included some of that trial data for you for this webinar. One of the nice features of basal insulin pens, and to be aware certainly of the different pen types. So with the Toujeo products, you have the SoloStar, with Tresiba, the Flex Touch. You can see different types of pens that are user-friendly and easy to use, and that can be an advantage for people, especially who have dexterity or challenges with administration. So those preloaded pens can be great. And there is opportunity to use, for example, the double star or the U200, which has pen capacities that are greater, which is especially valuable for people who are on a lot of insulin. They're not running to the pharmacy as much and can inject up to 160 units at any one time with these larger dose pens. So as much as I can talk about the type of insulin, titration is a key aspect to successful use of insulin. And the tradition, Canadian approach, which has been adopted throughout the world, has been this idea of going up by 1 unit per day. And I like that because it empowers people living with diabetes to titrate insulin on their own, as opposed to having to always go back to the healthcare professional to guide them on how to adjust their insulin. There is evidence with NPH, with glargine U100, with Detamir to do that. And even with glargine U300, we have that evidence. Now, insulin degludec U100 or U200 is a little bit more long-acting out of all the basal insulins we have. And so the recommendation is more to approach this with an adjustment every 3 to 4 days, or maybe once a week, by about 2 to 4 units per time. And again, with this titration, we would also remind people that they should be reducing their insulin if they're experiencing hypoglycemia. And if they're not at target for their fasting blood glucose, then to increase their insulin appropriately. It's all about the titration when it comes to insulin initiation. I mentioned that I would show you some of the time in range data, and this is an exciting trial because as opposed to traditional insulin trials, which have always looked towards A1C as being often the primary outcome. Now, there are some that look at other outcomes like hypoglycemia, but traditionally A1C has always been where the focus has been. This is now looking at time in range in the in-range trial as being the main focus as the primary outcome. And I think that is really a step in progress. Certainly as healthcare professionals, we're often using time in range with advancements in glucose sensing technology. And as well as people living with diabetes, understanding what their time in range should be and aiming to get there. It's great to see some data and the literature and scholarly work coming out in that respect. So this was a head-to-head randomized trial comparing glargine U300 to degludec U100 in people with type 1 diabetes. It was a 12-week multi-center randomized trial in adults with type 1 diabetes who had A1Cs between 7 and 10%, either on different kind of regimens, but a basal insulin analog with a rapid acting insulin analog. And then they were randomized to receive glargine U300 or degludec U100, and then followed with looking at primary and secondary outcomes. So again, the primary endpoint here was not A1C, but rather time in range, defined as sugars between 3.9 and 10. They also looked at glycemic variability. They did a stepwise hierarchy for their methods with looking at non-inferiority and then finally superiority, kind of in a stepwise fashion. And so the main highlight was that non-inferiority was achieved between glargine U300 and degludec U100 with time in range around 52 to 55%, which is actually pretty good. So now, of course, most people were aiming for a time in range over 70%, but what was nice to see is that there was no real difference between the two, and that many people did get a time in range that was at least encouraging in that respect. Glycemic variability, we generally aim for less than 36%. There was no statistical difference between glargine U300 and degludec 100 in terms of glycemic variability with these excellent basal insulins. And this was some secondary endpoints, but you can see how effective these agents are at lowering A1C. Now, it's not perfect time in range. It's not a perfect A1C, as the focus here is on basal insulin, and these individuals with type 1 diabetes need optimization of their bolus insulin as well. But again, we are seeing a kind of similar improvement in A1C and time in range when switching from a first generation basal insulin to these second generation basal insulin analogs. This is some of the descriptive data with time above range and time below range. As you can see here, not a huge difference between either product. And again, we're trying to minimize time above range and time below range in this trial. So I'm going to conclude this section with a case. This is a 66-year-old woman who's a shift worker with type 2 diabetes for 14 years, who has a BMI of 20 and an A1C of 8.2% and a fasting sugar of 10.1, a GFR of 50, and an albumin to creatinine ratio that's elevated at 17. And with type 2 diabetes, she's been on metformin, DPP-4 inhibitor, and an SG2 inhibitor with glargine U100, currently at 22 units. And the concern that she expresses is hypoglycemia happening on a weekly basis, usually overnight. And also, she's very concerned that her sugars are going up and down. And this would be somebody who would certainly benefit from being on some of those better glucose sensing technologies. But the question is, what might be some reasons she would be benefit from going to some of the second generation basal insulins, such as glargine U300 or degludec, like we just discussed, based upon our guidelines and trial evidence. And when I see that she's had diabetes for a long time, and that can predispose to more variability in hypoglycemia. She is quite lean, which could be a risk factor for hypoglycemia. Her A1C is above target, and that needs to be addressed. Her fasting sugars are at 10, which suggests that she needs more insulin, but on the other hand, she's having hypoglycemia. So we have to kind of find a strategy to improve her glycemic control, but not at the cost of too much hypoglycemia. I would also note that people who have impaired renal function are at higher risk for hypoglycemia. And so she may certainly benefit from a second generation basal insulin to help address glycemic variability, reduce hypoglycemia, and perhaps overall improve her quality of life and distress associated with her diabetes. So for the next topic we're going to discuss is biosimilar insulins. And this is certainly a hot topic in Canada right now in 2022. And the reason why this is so important is that private and public payers are now looking to biosimilar insulin options as they are a more cost-effective choice as basal or bolus insulin options. And so I think familiarity as healthcare professionals with these products are really important, and implementing them in practice in the right clinical context. So the old term for this is called subsequent entry biologics. We don't use that term anymore, but you might still see it in some of your readings. So the proper term is called a biosimilar biologic agent. And just to kind of give you the lay of the land here. So there's insulin glargine U100, which we've kind of talked about before, familiar to all of you as Lantus, which uses a solo star pen. And we've already talked about Toujeo, which is glargine U300 as the second generation. It's not considered the same thing as Lantus because although it's still the glargine molecule, it has a different kind of action profile. Now, the biosimilar insulin to Lantus, not to Toujeo, is Basaglar. Now, its pen is a quick pen, which is different than the SoloStar pen. It's really important, and this is a take-home message, to not be substituting one insulin type to the wrong insulin pen device. That is really important, and with all of the different types of insulin around, that can easily be mistaken, but it may not be a workable functional product if you use the wrong pen type with the wrong insulin. So certainly to be aware, especially amongst the reference and biosimilar insulins, to use the correct pen type. So far we have glargine U100, the biosimilar insulin, being called Basaglar in the quick pen format. There's also insulin Lispro, with the reference insulin being Humalog, which comes in a variety of different pens. Also, quick pen is its base kind of a preloaded pen. And its biosimilar insulin is called Admelog. And then there's insulin Aspart, with the reference insulin being Novorapid in a flex pen. and its equivalent being now Trurapi, which is in a SoloStar pen, along with Admelong, both of these being in a SoloStar pen. So the take-home message from this slide is that there are basal and bolus insulins that now come in biosimilar formats, and to be aware of the type of pen that you are using, be that with the reference or the biosimilar insulin. Now, sometimes when I've kind of thought about these biosimilar insulins, and when I've discussed this with my patients, we get into a discussion of, are these generic molecules? So it's kind of similar, but different. So let's just be very clear on the nomenclature. So generic are generally referred to small molecules. So you might have something like, familiar to us, generic metformin. These are smaller molecules like aspirin. And the manufacturing process involves a chemical synthesis of kind of mimicking the reference molecule. Now, biosimilars are different because they cannot mimic it the same way. It's a complex manufacturing process that is not synthetic, but rather based upon a biological process. And therefore, they're similar in biologics. You can see, for example, this antibody is a huge molecule and therefore cannot be kind of genericized, but rather must be replicated as a biosimilar. So insulins are biosimilar, but not generic. The data is important to show that the biosimilar product is very similar to the reference molecule with respect to efficacy and safety. Now, I did not want to get into all the nitty-gritty of all these trials, but suffice it to say that when you're recommending a biosimilar insulin, you are recommending it based upon, Health Canada recommendations, product monograph recommendations, Diabetes Canada recommendations, but also based upon study data. So the ELEMENT trials, looking at type 1 and type 2 diabetes, compared Lantus to Basaglar with the change in A1C, and it showed very similar efficacy between Basaglar and Lantus. This was looking at Humalog compared to Admelog, again in type 1 and type 2 diabetes in the Sorella trials, and again, very much similar with respect to A1C lowering with non-inferiority achieved. And finally, Trurapi compared to NovoRapid in the Gemelli trials over here, comparing type 1 and type 2 diabetes individuals, or NovoRapid versus Trurapi, and again, similar efficacy achieved. So I'm encouraged by the similar efficacy and safety data when we look at biosimilar insulins to the reference insulin in the basal and bolus groups. I wanted to highlight hypoglycemia, as that's one of the most important concerns around insulin. And again, we're seeing that very generally comparable between the biosimilar and the reference insulin for Lantus and Basaglar, for Admelog and Humalog, and for Trurapi and NovoRapid. The final question around biosimilar insulins has to do with immunogenicity. So if you're thinking about these as biological agents, perhaps they may develop antibodies that could make the insulin not effective or cause a different profile or change that. And so this has been studied, again, extensively in these trials, and all of them have a similar antibody and effect. So at the end of the day, that seems to be not a clinical meaningful concern. So to conclude this section, let's bring another case. This is a 52-year-old gentleman on metformin and glycoside. He is recently, unfortunately, laid off work, and this is just a reality of life, and has no drug plan, and was previously well controlled, was on an SG2 inhibitor, GLP-1 receptor agonist, Degludec is one of the second-generation basal insulins, but simply says, I know this was working for me, I simply cannot afford this anymore. I clinically appreciate the depression that's going on, and certainly this has been impacting his diet and exercise. And I think involving the whole diabetes healthcare team here, whether we can get some psychology and social work support, as well as seeing the nutritionist and working on behavior modification, all very important. But the reality is prescribing agents that are not affordable is not working for this gentleman at this time. The A1C is quite concerning at 9.5%, unfortunately not having hypoglycemia. But the question is, is there a role of biosimilar insulins in this situation, and I think very much so as a cost-effective yet safe alternative for this man to try and get the A1C controlled, but working like some of the very good basal insulins that we have, and perhaps even thinking about bolus insulin as well in a biosimilar format, as it might be more affordable and accessible to him compared to some of the other agents, which are great, but just challenging for him at this time. So the third section that I'm going to discuss is on practical considerations, and there is so much to discuss here in this webinar. And again, happy to entertain any questions or comments that you can feed back to Diabetes Canada, and we can have a healthcare community discussion on insulin for sure. And I'm sure that many of you across the country have some great practical tips that you can share, and our Diabetes Canada Forum for discussion is a great vehicle to share those. So certainly encouraging all of you to kind of get the conversation started here. But I've highlighted just a few kind of things that come to my mind on some practical considerations. First of all, going back to that biosimilar discussion, is when you're talking about starting somebody on a biosimilar, let's get practical. How do we do this? So initiation is very similar to the reference insulin. The switching is a one-to-one with respect to the reference insulin, and the dose change is similar to the reference insulin, and apologies for the typo. So basically, what we're saying is that the way you treat the biosimilar insulin, be that basal or bolus, is very similar to how you would manage a reference insulin. Now, with the second generation basal insulins, like glargine U300, as you can see here, or with degludec, which is Tresiba, how do you make that switch? So if they're on insulin glargine and you're going to Basaglar, maybe for, as we illustrated in case 2, you might reduce that insulin by 20%. Some suggestions to reduce if you're moving from glargine U300 to Tresiba by 20%, or you could keep it there and kind of just be prepared that you may need to reduce the insulin slightly. If they're on Lantus or Basaglar, that is being dosed once a day. You can use the same dose if you're switching to Toujeo, to Basaglar, or to Tresiba. However, if they're on BID glargine U100, then if you're going to Tresiba, you may reduce the dose by 20%. If you're switching to Toujeo, again, you could keep them on the same dose. You could also consider reducing by 20%. So when they're on BID, that's where you can open the discussion around reducing by 20%. If they're on Levemir, once a day, it's the same dose, but again, that Levemir or BID, especially going to Toujeo or Tresiba, to reduce by 20%. And with NPH, once a day, same dose, but NPH BID reduced by 20% for all of these basal insulin options. So I think that the bottom line is there's not necessarily a right or wrong answer, but it's anticipating the effect of making a switch and trying to prevent hypoglycemia. So if you're nervous, concerned, reluctant, probably reduce by 20%, and then you can always titrate up. Otherwise, for many options, you might be able to just keep them on the same dose and then adjust as needed. A big call out to our Diabetes Canada insulin initiation tool. So this is currently updated even from this slide on the guidelines. So please use the prescription tool. They do include the biosimilar insulins, the newer second generation insulins. And step 1 is to choose the insulin type. And the brand and the format. And again, this is on the section on practical considerations. And I do love the Diabetes Canada insulin initiation tool as a user-friendly format for starting insulin. You simply select the type of insulin, then you give a dosing and titration regimen. There's an excellent dosing tips as part of the prescription tool, and then you can titrate as appropriately. We did have some discussion earlier around appropriate titration for basal insulin, especially for some of the longer acting second generation basal insulin, to be considering titration, not necessarily every day, but maybe every 3 to 4 days or once a week. So be familiar with the type of insulin and then how you would titrate. We also highlighted the importance of using the appropriate pen device for the type of insulin, especially if you're switching the type of insulin they're on, making sure that it's the appropriate pen device, and educating people not to be switching from one pen to the other pen device inappropriately. Ensuring that they have supplies for pen needles, and also about glucose monitoring, other things like ketone strips if applicable. I think cost and consideration is absolutely important. So we can talk all day about the evidence from trials and guideline recommendations, but this must be individualized, and it's a little bit challenging to keep track of as it's moving all the time. So different provinces listed here, and this slide is probably out of date as I say this, as it's changing all the time. But it's important because, again, we want to be practical and we want people to recognize that prescribing something that people can't afford or access is not useful. Again, private and provincial payers are having different approaches to what's covered depending upon the product in the province. So just a call out for people to be familiar with that, and for cash paying patients to consider biosimilar insulins, as they generally are less expensive. Now, I certainly cannot do justice to this final topic here in one slide, but it's a reminder for all of us who are recommending insulin, and a shout out to all the diabetes educators who do this so well, that injection technique is as important, if not more important, than all of the stuff that we've been talking about today. So ensuring that the needle type is of the small generation at 4 millimeters. It doesn't matter the size of the individual, because it's only going through the skin into the subcutaneous tissue. So a 4 millimeter needle is generally recommended for all individuals. A reminder of the type of pen that they're on, and the usability of the different pens. How people inject is important, that we don't want people to put too much pressure at the injection site. Often skin folds are no longer necessary, and a highlight to look for a lipohypertrophy at every visit, and to remind people to vary their insulin sites to avoid lipohypertrophy, and as this can be certainly a significant source of hypoglycemia and variability in sugar control. And so a reminder just overall that the technique of insulin delivery is so important and must be reviewed on a regular and constant basis. So to summarize our discussion, second generation basal insulins may be preferred over first generation basal insulins based upon Diabetes Canada guidelines, based upon trial evidence. And some of the reasons for that may be once per day dosing, better flexibility, less variability, lower rates of hypoglycemia. And I think that it's great that these are an option for many people living with diabetes. Another great option to think about is biosimilar insulins, be that for basal or bolus options, largely because of being more affordable and encouraged by private and public payers. And I think the practical considerations are so important when starting insulin. Remember that titration is important, consideration of the type of insulin, basal, and then moving to bolus once per day, and then perhaps even more than once a day, using it with other agents, the monitoring of sugars, especially with advancements in glucose sensing technology, counseling around hypoglycemia with respect to prevention and treatment, proper timing of insulin administration, especially around bolus insulin being given preferably before meals, often 15 minutes before meals. The newer second generation basal insulins can be given morning or night, which can be great for shift workers or those who are traveling or those who may forget their insulin. And finally, rotation of sites and the proper insulin technique, so important to ensure success with insulin therapy. Bottom line is the insulin's been around a long time, and we've had a lot of advancement in type 2 diabetes with agents, but this is still a cornerstone of therapy. We remember that the beta cells of the pancreas decline over time, and that's the natural history of type 2 diabetes. And of course, for type 1 diabetes, insulin therapy is necessary. So I just wanted to thank Diabetes Canada for all the great work that they do around advocacy and helping people living with diabetes in this country. Thank you for asking me to speak. Thank you for all for listening to this webinar. And I wish everybody good health and success. Thank you so much.
A wonderful presentation. Thank you so much, Dr. Gilbert, for presenting. Again, if you have questions, feedback, comments, anything else, and you want to keep discussing today's topic, you can do so at community.diabetes.ca. Dr. Gilbert will be in the community answering your questions. Again, this is a members community. You can become a member at diabetes.ca/membership, or give us a call or sending us an email, and we'll get you all set up. If you enjoyed today's presentation, of course, it is freely available for you to enjoy, but we would delight if you would consider making a donation. You can visit us at diabetes.ca/donation. We're a registered charity, which relies on the support of donors like you. Your gift will help fund all areas of our work, including make sure we can keep making webinars just like this. Again, let's continue the discussion over at community.diabetes.ca, and have a wonderful day.